Now, my charge today is to discuss what I see on a diagnostic perspective on a day-to-day basis when a patient presents to the office for an all-on-4 type of restoration. Now, there are many things that have changed in implant dentistry, but one thing which hasn't changed is that it's still a prosthetically driven discipline. Patients don't come to us for titanium. They come to us to get a set of functioning teeth which look good and feel good. And that's where close collaboration between the surgical and restorative team come in, because without the surgeons, we can't do any of this. Now, we're going to be discussing, several factors, and the title of my presentation was "Begin with the End in Mind." What does that actually mean? Beginning with the end in mind is different for the patient, and it's really different for the clinician. For the patient, it's, I'm going to get teeth, I'm going to improve my confidence, I'm going to get my life back. And for the clinician is, how do we get there? So the questions we really ask is, what does the patient want, and how do we really get there? So what does the patient want? Most patients, if given a choice, if they're attending for dental implant treatment, their preference would be to have a fixed restoration. Right, something that they don't remove from their mouth if possible. And as clinicians, we have to decide if that is truly possible. Other things we have to think about, we've got to think about maintenance, we've got to think about hygiene, and we've got to think about complications and also cost. But contrary to popular belief, cost is never the deciding factor for a patient who is going to move forward with treatment or not. Now, there are many clinical parameters that we look at to decide whether the patient is suitable for a fixed versus a removable restoration. But before we get in there, let's see what the patient wants. What is the patient's preference? So I pulled a couple of studies, and these studies were essentially asking patients what they preferred, fixed versus a removable. And the results were very different, depending on whether you were in the US or whether you were in Europe. In the US, patients preferred fixed restorations. And in Europe, they preferred overdentures because they could remove them. Now, which type of prosthesis has higher complications? Without a shadow of a doubt, the literature will show that patients with implant-supported overdentures have more complications. They're easy to handle, and the complications actually increase with time. With fixed restorations, the complications were in the posterior aspect of the prosthesis, and they didn't increase with time. So fixed restorations are a lot more stable. Which leads us into cost. Is cost an influencing factor? And when we look at cost, we've got to look at cost from two perspectives. Cost for the patient and cost for the clinician. On occasion, many clinicians, because of fear of presenting the fee to the patient, they start talking about removable options so that the patients will accept treatment. And that may be less costly for the patient, but it's actually more costly for us in the long term because of the maintenance that we have to go through. So how do we get there? What are the diagnostic things that we look at to determine if a patient is a candidate for a fixed versus a removable? And there are 7 things that we look at. As with any type of rehabilitation, whether it's implant-supported, a complete denture, or a full mouth rehabilitation on teeth, we always start with the incisal edge position. Positioning the central incisor correctly in the patient's face. Where do we get that information from? We have it in the literature. It's display, it's F position, it's S sound. The other thing we have to position is the mandibular incisal edge position. This is not aesthetically positioned. This is positioned for function, for appropriate guidance, appropriate distribution of forces throughout the mouth. So when you compare these two patients side by side and ask yourself, is the incisal edge in the correct position? The one on your right, we obviously have to reposition the incisal edge a little bit further up and a little bit further back. Now, how does that impact our treatment planning and our communication to our surgeon? Obviously, in this type of scenario, we will have to do some alveolectomy prior to implant placement to make enough room for prosthetic material. So when a patient who comes in and they're edentulous, the first thing we do is a diagnostic denture setup. We ask the patient to smile, and we ask ourselves, is this a patient for a fixed versus a removable? This patient obviously is a candidate for a fixed restoration. And the question becomes, can you do an all-on-4 on this type of restoration? I think many people have the misconception that an all-on-4 can only be done if you have pink prosthetics and you have to remove bone every single time. Absolutely not true. This patient would be a candidate, but we may be doing zirconia, fixed crown and bridge work on this type of patient. This is your typical all-on-4 classic type of situation where we've got adequate pink prosthetics. The next thing we look at is restorative space. How much space do we really need to pull this off? And it really depends which material you're using and the type of restorative design you're going to employ. For ceramic restorations, 9 to 12 millimeters. For acrylic-based restorations, we're looking at about 16 millimeters. What happens if we don't have that space? Simple, something breaks. And it'll break in the immediate load provisional, and it'll break in the final restoration, and it'll break sooner than we want it to. The next thing we look for is lip support. This is absolutely key when deciding between fixed and removable. What we do is we get the patient in, take a lateral shot with the denture in, and then we take a lateral shot with the denture out, and then we're looking at the nasolabial angle to see if there's sufficient support for the patient's lip, or does the patient need the flange of a removable restoration. This lady had her teeth extracted 25 years ago. It's a wedding present from her husband, believe it or not. She wanted to look good in her wedding pictures, but you can see with this amount of resorption, she may need the flange of a removable appliance for that lip support. So when a patient comes in, how do we decipher that? We fabricate a new denture setup. That denture setup essentially will be flange-less. So we can see if we can position the teeth, and if the patient has adequate bone, we can go ahead and place the implants and be fairly confident that we're going to give the patient a fixed restoration. Right, because we're trying to develop that straight, nice emergence profile, which is also cleansable. And once again, it has to look correct in the patient's face. Next thing we look for is smile line and lip length. And when we're looking at smile line, the literature has shown low, medium, and high smile line, and the patient to your right-hand side would be your worst nightmare for a single tooth or for an all-on-4 type of restoration. Very, very challenging patient to treat. How do you reposition that lip? There are many authors talking about surgical lip repositioning, Botox, various other things, but we have to come to a diagnosis before we make those treatment decisions. So lip length, essentially, if the patient presents with a high smile line and a low lip length, this is the danger. We may end up exposing the transition zone, and this is not a good day for anybody. Patients presenting with a long lip length, low smile line are much more forgiving. And these are the type of patients, if we're just starting out on this all-on-4 journey, this is the type of patient you want to look for, because if something doesn't go so well, the patient's lip can at least hide that. We have to come to a diagnosis as to what is causing the excessive gingival display. Now, we talk a lot about edentulous patients. Most of the patients we treat in our practice today, I would say 70 to 80% are with a terminal dentition. They have teeth, and some of them present with excessive gingival display. And we've got to come to a diagnosis before we implement our treatment plan. It may not just be bone reduction is required. The relevance of this, what type of prosthesis are we going to do? Are we going to use pink prosthetics or not? How much bone reduction is there going to be? These are all questions we have to answer before we rush in and do this type of restoration. For edentulous patients, it's fairly straightforward. We ask them to remove the denture, smile really big, and they're going to give us a really funny look. Why is he asking me to smile without my denture? There's a specific reason. We're looking for ridge display. And in this patient, there's no ridge display, so we can be quite confident that we're going to hide that transition line. But if a patient comes in like this, and the ridge is displayed, that's a red flag. We have to do something about that to hide that transition zone. When this patient comes in, I say to them, you know, when you had your teeth, did you have a gummy smile? And what do they normally say? No, I didn't. My teeth were absolutely perfect. We know they weren't, right? So we have to do something about that excessive gingival display. Otherwise, problems like this will occur. Now, when we're repositioning the transition zone, there are certain guidelines, there are certain bone reduction guides. We don't have enough time to go into that today. Simply said, when the patient smiles with their highest smile line, that transition zone should be well hidden. The next thing we look for is contours and emergence. Contours and emergence is a function of space. How much space do we have? I would tell you, as a restorative doctor, I want as much space as you can give me. But the reality is that it's a surgical responsibility, and that's where close collaboration between surgical and prosthetic teams come in so that we can get the contours that we desire. Take this patient, for example. Is it possible to treat this type of patient with a fixed restoration? Because in the beginning I said, most patients that come to see us, they really want a fixed restoration. We have to think about the problems. Excessive amount of resorption, lip support is a huge issue. What are going to be the potential ramifications of this on clinical treatment? The implants are placed further palatally, the incisal edge is placed further forward, and we have this ledge. Okay, and that ledge is awful in terms of hygiene, it's a food trap, it's really not comfortable for the patient. So how can we go about eliminating these types of contours? Right? Because this is the problem that we want to avoid. In situations like that, if there's sufficient bone availability, the implants can be placed a little bit higher up, and the contours started a little bit further up from the implant. What does that mean? We may need to use shorter implants. I think there's good evidence to show that shorter implants splinted in a full arch situation do have longevity. If the patient doesn't like the look of the restoration and they have this shelf and they can't maintain it, we're really not doing the patient or ourselves any favors long term. Okay, so everything that we've talked about thus far, lip length, smile line, restorative space, it all culminates in the need for bone reduction. Once again, I will reiterate that I think we should do just as much bone reduction as we need to. We don't haphazardly have to go in and take away 8, 10, 15 millimeters of bone just to place the implants. You know, there are specific indications for bone reduction: hiding the transition zone, creating space, creating contours, having an adequate volume of bone to put the implants in. So we're just doing enough bone reduction to satisfy the restorative and the hygiene concerns. What about our immediate provisional restoration? The provisional restoration on the day of immediate loading has to satisfy all the criteria of your definitive restoration. Just like with any aspect of dentistry, whether you're doing veneers, crowns, we have to develop our tissue contours, we have to develop our shape, we have to satisfy the speech requirements in our provisional restorations. And that provisional restoration, over a period of time, we're going to be adding acrylic to it to compress the tissue so that we can develop a nice concave tissue surface, so our restoration surface is convex and makes it much easier for the patient to clean. The last thing we look at as far as the provisional restoration is concerned is appropriate occlusal contact. Now, occlusion is I wouldn't say a controversial subject, but everybody seems to have an opinion on it. And there's really no solid scientific evidence for occlusion on implant-supported restorations. And it really depends on where you're trained. There's no study to show that one occlusal scheme is better than another, one patient prefers an occlusal scheme to another. So it's really a matter of biomechanics. So in the immediate load provisional, the day of implant surgery and the day of loading, what type of occlusion are you going to put on that restoration? Now, if I was to ask you, where is the weakest quality bone? It's further back, right? Posterior maxilla, posterior mandible. Where is the highest force? Further back. Once again, the closer we move towards the jaw joint, the higher the force. So based on that rationale and based on biomechanic rationale, the occlusion on these immediate load restorations is positioned further towards the front, and it limits the amount of force that the patient can put on those restorations. Obviously, with the surgeon's going to provide good AP distribution, we're not going to have any cantilevers, no premature contacts, but the occlusion essentially will be on those front teeth. So I hope in my short 15 minutes, I gave you some guidelines to think about, and with that, I'd like to thank you for your time and attention.